Gleason classification is subjective. Should biopsy tissues be sent to an expert prostate pathologist to confirm Gleason's score?
We're fortunate to work at a center where we have expert pathologists. I think that that's an excellent idea. The more experienced your pathologist is, I think the better diagnosis you will get. I think academic centers have shown that they have fewer incidences of upgrading at time of prostatectomy, and so this is it's a great idea.
Thank you, doctor. The next question is, what is the rate of occurrence in these genetic tests, if any, of results indicating lower risk in the case of higher Gleason scores?
Yeah, so that's an interesting point. We have been typically reserving active surveillance for guys with Gleason 6 disease and low volume disease, but I think there are some people who are starting to extend that indication to guys with low volume Gleason 7 disease, and so if you study some of these validation tests looking at the Oncotype DX and the Polaris test, there actually tends to be more separation between the test scores for the Gleason 7 disease patients rather than the Gleason 6 disease patients. And so some of these guys with Gleason 7, according to the genetic tests, are going to be as indolent as some of the Gleason 6 prostate cancers. And so the relative percentage is small, but the test does seem to pick these gentlemen out. So for somebody who is really considering active surveillance, they have low volume intermediate risk disease, a genetic test may be worthwhile to see if they could potentially be an active surveillance candidate.
Thank you, doctor. The next one is, do those of us with artificial hip joints not qualify for the MRI scans due to the metal in the artificial hip implant? Doesn't the metal scatter the MRI signal and ruin the results?
Right. We still order the MRI for patients with hip replacements. The picture doesn't come out as clearly, not as well defined, but I think we still get a really good study for most of the patients and can get some valuable information.
The next one is, with recurrent prostate cancer, how frequently should full body bone scans be done when no mets are found? Annually, twice per year, or some other?
So in the situation where after treatment, after surgery, we just follow the PSAs. And if somebody's PSA is undetectable, then we won't usually do any further imaging. For gentlemen who are undergoing active surveillance, we'll typically not do any bone scans. I have been ordering MRIs periodically for these guys on top of the PSAs and the regular biopsies that they should undergo. But again, no regular bone scan schedule.
Thank you. Where can one obtain a genomic test? Does Medicare approve it?
So Medicare does approve the Polaris test, and I think they're very close with the Decipher test. It may be now covered. So as far as I know, there are no private insurances that cover either of those tests, but Medicare, I think, is covering both of those. As far as how to obtain one, patients can ask their physicians to order it for them. The way that it typically runs is the order goes into the company, and then the company will contact the laboratory where the prostate biopsy is sitting, the actual slides. And so, depending on whether there's a relationship there already, there may be some lag time to, set up all the contracting that way. But if there's a contract set up, then, the slides will go out very shortly, and then we usually get turnaround in around 2 or 3 weeks as far as the test results go. And then that test result comes back to the ordering physician, and then the physician can review the test results with the patient then.
Thank you. What is the ideal PSA number that a man should achieve before attempting either C11 choline or acetate imaging? For PET scans, it's a continuous spectrum that there will probably be very few gentlemen who have a positive PET scan with a PSA less than 1. It'll probably be closer to 5 where you will actually see some activity on a PET scan. It would probably be, a minimum of 1. But that I think makes it a little bit more difficult to use as a decision-making tool, because, in the situation where somebody has a early recurrence after prostatectomy, then the guys will usually get salvage radiation, well before their PSA hits 1. So,
Dr. Lee,
thank
I
you,
can
Doctor.
speak to that, I'm sorry, from personal experience.
Yes, sure, Paul. Please go ahead.
Okay, thanks. I underwent C11 choline imaging, but I was told at the time, this was 4 years ago, that I needed to have a PSA of 2 or above to qualify. Yeah. So I deliberately allowed my PSA to rise to that level so that the imaging would be better. Has that changed in the 4 or 5 years since I did that?
So did you have surgery first?
Oh, this was
then?
After surgery, after radiation,
yes.
after ADT.
After surgery. Gotcha. Yeah. Okay. Yeah. No, I think that would be what most people would recommend. I've seen a study or two where they say that they can see some patients who have a positive PET scan at a PSA of only 1, but I don't think we would typically order it still in that setting. It would probably be more at a level of closer to 5.
I see.
Yeah.
Thank you.
Yeah, thank you.
So we have about another 10 minutes. Perhaps, do any of the panel have any other questions they'd like to ask Dr. Lee?
Oh, you know me. I always have a lot of questions.
Oh, go right ahead.
Something Tony asked caused me to think of something. How many years after a prostatectomy has been performed can genetic testing be of use? For example, my tissue is from 2007. Could I get a genetic test now?
It's probably just a hair late now. I think the companies generally say that up to 5 years they can still get very, very reproducible data.
Oh, that's fascinating. Okay, thank you for that. I had no idea.
Sure. It's really interesting technology, and I think we're going to learn to use this better and better over time. And then as people get more comfortable with the idea that these tests are out there, then everybody will feel more comfortable with it and figure out how to use it appropriately.
Sure.
So, Dr. Lee, there are now several of these tests are on the market, several more in development. Are you concerned in any way that we have no head-to-head data on the relative quality of these tests?
Right. Yeah. Still, as far as these 3 tests go, that still isn't there yet. I think what is going on is, like the Decipher test is really just focused at the post-prostatectomy setting, but now they're starting to build their case to be used as a biopsy decision-making tool. Likewise, the Oncotype test now is just for the biopsy setting, but they're working to develop their data to be used in the post-prostatectomy setting. That's really what people are working on. We are actually ordering a lot of these tests for the high-risk guys, both the Polaris and the Decipher, and hopefully we'll accrue some data which will give us some idea whether one is better than the other or more predictive than the other. But the test results are still, they have their own definitions as far as what they're predicting. So it's a little bit difficult to compare them one-on-one.
Any other questions for the panel, Meryl?
Well,
nope.
To that left.
Excellent presentation.
Tony, go ahead.
I was going to say an excellent presentation. Thank you so much.
Oh no, thank you for your questions.
Tony?
I did have one follow-up question.
Go for it.
Yeah, please.
Okay. Do the current genomic tests currently on the market give an indication as to which drugs might be more effective or less effective for those of us with advanced prostate cancer? Like, we've not yet progressed to extend to urine enzalutamide. It might work, might not. Do we take the chance? Does a genetic test maybe help?
Yeah, no, I think that's a huge area of future research. And then, not only this, because this whole idea that Vice President Biden now is heading up as far as the moonshot for cancer cure goes.
More power to him.
It's going to be, I think, a lot of personalized medicine where you really hone in on the genetics of what's going on with a particular patient's cancer, and then really tailor the treatment to that patient. Because cancer formation and proliferation is really such a personalized event. There are certain genetic pathways which are mutated, but they're probably very different from patient to patient. So looking at what the specific defect, so to speak, is, I think is going to be very important, and it's really going to help us to figure out, whether a patient may benefit from a certain type of radiation or a certain dosage of radiation, or, what kind of hormonal therapy that they would work well with, or what type of chemotherapy plus or minus hormone therapy that the patients would do best with. So this whole field for prostate cancer genetics, I think, is, it's just starting. It's very much behind the times compared to like breast cancer, where, there's really actionable data as far as, what type of therapies to administer to women based on what their genetic profile looks like. But hopefully with these new tests coming out, we're going to make an impact this way.
Understood. So not yet, but soon, we think. Thank you.
Hopefully,
I think that as time we move along, we're going to continue to see more uses of the genomics and the definitions of translational medicine and into drug sequencing. I think that's kind of what you were summarizing right there, Dr. Lee. And I think that perhaps there's got to be a starting point someplace, and I know that it's back to those tissue depositories and trying to look at outcomes and see if we can find genetic markers. Let me ask you a question. Do you feel, how long do you think it would take for us to come up with perhaps a nice way to break down a lot of the genetic biomarkers that we see down out there and actually start to see some of these translational medicines hitting the street?
It might not take that long. I think that one of the big hurdles these days just is this uncertainty, as to what genes are really important as far as targeting goes. Some of the immunotherapy agents, have some promise, but then, where do they function? Where do they target? As far as the Decipher test goes, it's interesting. Some of the genes that they look at, which they found, which are very correlated to poor outcomes in the long run, they're not really even certain how these genes impact the cancer. And so, trying to figure out this tangle, so to speak, of cellular function and where things have, gone astray is very perplexing. And then, as far as prostate cancer goes, there's such a preponderance towards low risk prostate cancer that it's hard to figure out then, which of the guys who really need to be treated aggressively, the guys with high risk, what are the specific, genes which, lend more towards less aggressive disease and more towards the high risk disease, and then to target those things specifically. So, I think it's this informational gap that exists.
So, Dr. Lee, I think we've reached pretty much the end of our hour, and I would really like to thank you on behalf of all of the panel and the audience for your time this evening. I hope that you've enjoyed speaking with us, and I'm going to hand this back to Priya to close out the rest of the program. So thank you very much for your time.
Great. No, thank you. Thank you, everybody.
Thank you.
Thank you.
Dr. Lee, thank you very much for that very informative session. Mike, Tony, Paul, and Meryl, thank you for your participation. This talk will be made available on Cure Talks website along with its transcript. Please visit curetalks.com for details of upcoming talks. And thank you, everyone.
Thank you, everyone. Good night.
Thank you for hosting.
Thank you.
Good night.